This is a lecture on strokes. In terms of regulation of cerebral blood flow, it's controlled by autoregulatory mechanisms or local mechanisms that respond to metabolic needs of the brain. Autoregulation is sufficient within a range of 50 to 150 millimeters of mercury. Three metabolic factors that affect cerebral blood flow are: one, an increase in carbon dioxide, which increases cerebral blood flow. Carbon dioxide leads to vasodilation, so then that causes CO2 in the blood to be doubled. That doubles cerebral blood flow. The second factor is an increase in hydrogen ion concentration. Carbon dioxide combines with water to form carbonic acid. It then dissociates, or hydrogen ions dissociate. As a result, vasodilation of cerebral vessels occur. The third factor is that there's an oxygen deficiency. If blood flow to the brain leads to a decrease in oxygen sufficiency, then that causes cerebral vessels to dilate as well, returning cerebral blood flow to near normal. In terms of the sympathetic nervous system, when local mechanisms fail, the sympathetic control of cerebral blood vessels, or cerebral blood pressure, becomes very important. For example, when the arterial pressure rises high during strenuous exercise, the sympathetic nervous system constricts the large and immediate-sized superficial blood vessels as a means of protecting smaller, more easily damaged vessels. 80% of all strokes are ischemic, and 8 to 18% of all strokes are hemorrhagic. Stroke is characterized by a sudden impairment of cerebral circulation in one or more of the vessels supplying the brain. It's also previously been called cerebrovascular accident or stroke syndrome. Stroke is a non-specific term that encompasses an heterogeneous group of pathophysiologic causes, to include thrombosis, embolism, TIA, lacunar infarct, and hemorrhage. Strokes are broadly classified as either being hemorrhagic or ischemic. With ischemic strokes, they are caused by an interruption of blood flow in cerebral vessels. The most common type of strokes accounts for 87% of all strokes, ischemic strokes. They're the most common. Hemorrhagic strokes are less common. They're caused by bleeding into brain tissue. And usually this is from a rupture in the blood vessel caused by hypertension, aneurysm, and AV malformation, head injury, or blood dyscrasias. It has a much higher fatality rate than ischemic stroke. In terms of risk factors for strokes, just briefly assessing the risk factors for stroke may provide clues as to its cause and reinforce the clinical gestalt that clinicians may have in uncertain situations. With ischemic strokes, risk factors for ischemic stroke include advanced age. The risk doubles every decade. Smoking is another risk factor. In terms of heart disease, issues such as coronary artery disease or left ventricular hypertrophy, chronic AFib predispose a person to clot formation. Hypercholesterolemia is another factor. In terms of ethnicity, African Americans have almost 2 times the risk of first ever strokes as Caucasians. Persons with sickle cell disease. During a sickle cell crisis, that predisposes the person to forming clots in cerebral vessels. In terms of gender, men have a greater incidence than women at younger ages. The risk of stroke increases with age, especially in persons over the age of 64, persons with hypertension, persons with blood pressures that are above 120 over 80 are at an increased risk. So it's important to keep your numbers below 120 for the top number and below 80 for the bottom number. If you do, then you decrease your risk by half. Issues with elevated homocysteine levels has been identified as risk factors for all forms of stroke. Diseases associated with increased blood viscosity and the use of oral contraceptives place patients at a higher risk for ischemic stroke. Estrogen plus, progesterone, as well as estrogen alone, increases stroke risk in postmenopausal women. Previous cerebrovascular disease data suggests that roughly 10% of patients with TIA suffer stroke within 90 days, and half of these patients suffer with stroke within 2 days. Heavy alcohol consumption is another. That leads to hypertension, hypercoagulability of blood, and the reduction in cerebral blood flow and greater likelihood of AFib. Persons who use cocaine, that causes both hemorrhagic and ischemic strokes by inducing vasospasm and enhancing platelet activity. There's also increase in blood pressure, heart rate, body temperature, and metabolic rate. Between 200,000 and 500,000 transient ischemic attacks are diagnosed every year in the United States. A TIA is a brief episode of neurodysfunction that results from a focal cerebral ischemia episode and is not associated with infarction. So a TIA, or a mini stroke, is equivalent to brain angina and reflects a temporary disturbance in cerebral blood flow, which reverses before infarction. A traditional definition before more advanced methods of neuroimaging were available was a neural deficit resolving within 24 hours. Now, a more accurate definition is a deficit lasting less than an hour and is best described as numbra, which is an ischemic band or an area minimally perfused cells without central infarction. Both are warning signs, however, of impending stroke. Twenty percent of ischemic strokes are thrombotic strokes, and that occur when there are thrombi that develop. When you have a decrease in blood flow due to atherosclerotic blood vessels, that can cause clots or thrombi to form. If you have a thrombus, then blood is not going to flow all that well, and that results in ischemia. So thrombi are most commonly caused by ischemic strokes, and they usually occur in atherosclerotic blood vessels. In terms of your pathoschematic here, the common sites of plaque formation are in the larger vessels, and notably the origins of the internal carotid artery and vertebral arteries, and the junctions of basilar and vertebral arteries. These infarcts often affect the cortex, causing aphasia or neglect, visual field defects, transient monocular blindness, and usually with thrombotic strokes, they're seen in older persons and frequently are accompanied by evidence of atherosclerotic heart and peripheral artery disease. Lacunar infarcts. 25% of strokes are lacunar infarcts. A lacunar stroke will result from occlusion of the small perforating arteries of the deep subcortical areas of the brain. The infarcts are generally less than 15 millimeters wide. The most common lacunar syndrome include pure motor, pure sensory, and ataxic hemoperitic strokes. Lacunar infarcts are often associated with partial or full occlusion of the parent feeding artery. Lacunar strokes account for 13 to 20% of cerebral infarcts, and lacunar infarcts commonly occur in patients with small vessel disease, such as diabetes and hypertension due to arterial sclerosis. By virtue of their small size and well-defined subcortical location, lacunar infarcts do not lead to impairments in cognition, memory, speech, or level of consciousness. In the process of healing, however, the lacunar infarcts leave behind small cavities or lacunae, lakes. Signs and symptoms are dysarthria, so the person will have difficulty pronouncing words, and this is different than aphasia because it's due to a weakness of lips and the tongue and the larynx muscles. And they also have an issue with clumsy hand syndrome. 20% of acute strokes are embolic strokes. So for cardiogenic embolic stroke, it's caused by a moving blood clot that travels from its origin to the brain. It usually affects larger proximal cerebral blood vessels, often lodging at bifurcations, for example, the middle cerebral artery. Although most cerebral emboli originate from a thrombus in the left heart, they may also originate in an atherosclerotic plaque in the carotid arteries. The embolus travels quickly to the brain and becomes lodged in a smaller artery through which it cannot pass. An embolic stroke usually has a sudden onset with immediate maximum deficit. Various cardiac conditions predispose to formation of an emboli that produce an embolic stroke, and these are rheumatic heart disease, AFib, a recent MI, ventricular aneurysms, and bacterial endocarditis. Only 8 to 18% of strokes are hemorrhagic. The most frequently fatal stroke is a spontaneous hemorrhage into the brain substance, resulting in an intracerebral hemorrhage. With rupture of a blood vessel, hemorrhage into the brain tissue occurs. As a result, a focal hematoma and sometimes an intraventricular hemorrhage will occur with edema and compression of the brain centers or a spasm of the adjacent blood vessels. The most common predisposing factor are advanced aging and also high blood pressure. Other causes of hemorrhage are aneurysm, trauma, erosion of the vessels by tumors, AV malformations, blood coagulation disorders, vasculitis, and drugs. Signs and symptoms: vomiting occur at the onset, headache often occurs, there's contralateral hemiplegia with initial flaccidity progressing to spasticity if the hemorrhage is in the basal ganglia. And the hemorrhage and the resulting edema exert great pressure on the brain substance, and the clinical course progresses very rapidly to a coma and frequently to death. Treatment or management of an increased ICP and an increased arterial pressure and prevention of recurrent hemorrhage are the targets. So there's recombinant factor 7 that is used for treating bleeding disorders in persons with hemophilia who have antibodies to 8 and 9. This is just a figure to break down your thrombotic versus your embolic and hemorrhagic stroke. So again, with your thrombotic stroke, you have cerebral thrombosis. That causes a narrowing of the artery. That narrowing or the atherosclerotic plaque is caused by an accumulation of fatty deposits. And as a result, you have slowed blood flow through that artery. So it's very easy for the person to have a stroke. For an embolic stroke, you have an embolus. That's a blood clot that has dislodged and is now circulating in the blood. When it reaches an artery in the brain that is too narrow to pass through, it lodges there, it blocks the flow of blood, and so then you have brain angina or a stroke. For the hemorrhagic stroke, there's a burst in a blood vessel that allows blood to seep into and the damaged brain tissues until clotting shuts off the leak. In terms of the patho for a stroke, there are cellular level changes that begin 4 to 5 minutes after blood flow and oxygenation of neurons are reduced. The sodium pump and neurotransmitters fail as a result of anaerobic glycolysis, resulting in cerebral edema as sodium draws water into the brain. Cerebral blood vessel walls swell, circulation is compromised, and vasospasms are combined with a blood viscosity, reducing cerebral perfusion. Outcomes of decreased cerebral perfusion lead to cerebral anoxia caused by interruption of blood supply to the brain, cerebral infarction if anoxia lasts longer than 10 minutes, which results in irreversible changes. There's cerebral edema causing secondary damage. Contralateral deficits occur when the stroke is in the cerebral hemisphere, and there can be permanent deficits reflecting the locality of the stroke. For signs and symptoms, there's an altered LOC or unconsciousness. There's a change in breathing pattern. The pupils are unequal. Larger pupils are noted on the same side as the stroke. There's paralysis of one side. The person perspires. There's aphasia. So there's an abnormal or absent speech. They often have a blank stare, dysphagia, inability to make decisions, loss of memory, and have gait instability. When you look at secondary injury, we're talking about the chemical aspect of it. So that's ischemia and hypoxia. Whenever there's ischemia, you have a massive release of glutamate. That leads to glutamate overstimulation. And as a result, you have an increase in sodium. If you have an increase in sodium, water will follow. There's also an increased calcium that comes into the cell and potassium out of the cell. That leads to an increased need for ATP to pump ions out. Because you don't have oxygen, you can't run aerobic glycolysis. So you're not going to get the ATP that you need, the amount that you need. So without this oxygen, you run anaerobic metabolism. And as a result of that, you're going to build up plenty of lactic acid. So this is why you have acidosis and cell death. The other thing that's occurring with ischemia and hypoxia is that will cause a breakdown in cell membranes, and arachidonic acid and formation of oxygen-free radicals will occur. Those free radicals bind the other membranes, causing rupture, and cell death leads to more free radicals and more cell death. So it's perpetuating itself. So manifestations that will reflect the location of injury on a neural exam with the availability of thrombolytic therapy for acute ischemic stroke in selected patients. They must be able to perform a brief but accurate neural exam on patients with suspected stroke syndrome. The goals of the neural exam include confirming the presence of a stroke syndrome, to be defined further by cranial CT scanning. Other goals would be to distinguish the stroke from stroke mimics and to establish a neural baseline should the patient's condition improve or deteriorate. Essential components of the neural exam include evaluating the mental status and the level of consciousness, checking cranial nerves, motor function, sensory function, cerebellar function, gait, deep tendon reflexes. The skull and spine also should be examined, and signs of meningitis should be sought. Central facial features or weakness from a stroke should be differentiated from peripheral weakness of Bell's palsy. With peripheral lesions or Bell palsy, the patient is unable to lift the eyebrows or wrinkle the forehead. The four principal neuroanatomic stroke syndromes are caused by disruption of their respective cerebrovascular distributions. Correlating the patient's neural deficits with the expected site of arterial compromise can assist in confirming the diagnosis of stroke and interrupting the subsequent cranial CT scan. For middle cerebral artery (MCA) occlusion, that commonly produces contralateral hemopharesis, contralateral hyposthesia, ipsilateral hemianopsia, and gaze preference toward the side of the lesion. There's agnosia, that's very common, and there's receptive or expressive aphasia that may result if the lesion occurs in the dominant hemisphere. Neglect, inattention, and extension of double simultaneous stimulation may result in a non-dominant hemisphere lesion. Since the MCA supplies the upper extremity motor strip, weakness of the arm and face is usually worse than that of the lower limb. With your anterior cerebral artery conclusions that primarily affect the frontal lobe function and can result in dishibition and speech perseveration, that produces primitive reflexes. For example, grasping, sucking reflexes, altered mental status, impaired judgment, contralateral weakness, and the weakness will be greater in the legs than in the arms. There's also contralateral cortical sensory deficits, gait apraxia, and urinary incontinence. With the posterior cerebral artery, occlusions affect vision and thought, producing contralateral hemianopsia, cortical blindness, visual agnosia, and altered mental status, and impaired memory. For vertebral basilar artery occlusions, they are notoriously difficult to detect because they cause a wide variety of cranial nerve, cerebellar, and brainstem deficits. These include vertigo, nystagmus, diplopia, visual field deficits, dysphagia, dysarthria, facial hyperesthesia, syncope, and ataxia. A hallmark of posterior circulation stroke is that there are cross findings, ipsilateral cranial nerve deficits, and contralateral motor deficits. This is contrasted to anterior strokes, which produce only unilateral findings. Lacunar strokes result from occlusion of the small perforating arteries of the deep subcortical areas of the brain. And the infarcts are generally from 2 to 20 millimeters in diameter. The most common lacunar syndrome includes poor memory, poor sensory, ataxic, hemopyritic strokes. Lacunar infarcts are often associated with parietal or full occlusion of the parent feeding artery. By virtue their small size and well-defined subcortical location, lacunar infarcts do not lead to impairments in cognition, memory, speech, or level of consciousness. In terms of nursing management, you want to look at vision. Provide care with recognition of hemianopia, diplopia, or decreased acuity. Place a patch over one eye to reduce double vision. For safety purposes, explore what life will be like in the home setting with new deficits. Provide safety assessment for the home setting. Identify areas to modify based on fall risk. Create a plan with the client and family to optimize return to their community. and identify support services and recognizing warning signs of another stroke event. In terms of sensory deprivation, create a plan to optimize balance and sensory stimulation. Provide appropriate repetition for learning. And reference to behavioral changes. Educate the family as to the causes and approaches um, that will occur, and loss of inhibitions, fear, anger, and depression. Management of strokes involves diagnostics, thrombolytic treatment, such as TPA, and anticoagulants as well as antiplatelets, and controlling cerebral edema. This concludes the lecture on strokes. If having questions, please contact me at halef@hawaii.edu.